Welcome everyone to today's webinar, How Owensboro and Montefiore Use Time-Driven Costing to Crack the Code on Cost. I am Brian Zimmerman, Custom Content Editor at Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Jason Oliveira is Director of Decision Support Services at Montefiore Health System. He supports financial analytics, performance management, and program planning for operations leadership across the system's 8 campuses, 7 hospitals, 150 skilled nursing beds, certified home health agency, and 200+ ambulatory sites. He has devoted his 36-year career to healthcare providers at New York City Health and Hospitals Corporation, New York Presbyterian Hospitals, Kurt Salmon Associates, and Deloitte Consulting, with a particular focus on business intelligence, financial analytics, health information technology, and performance management. Jason earned his BBA in computer systems design and his MBA in healthcare administration. Jeremy Stewart is a decision support leader in the financial sector of the hospital and healthcare industry. He has over 13 years experience in healthcare finance, including roles in general accounting, budgeting, data analytics, reimbursement analytics, decision support, and cost accounting. His experience includes partnering with hospital executives and clinicians to improve clinical and financial outcomes through the appropriate and effective use of data technology and decision support services. Jeremy has been a member of HFMA since 2011 and led the first team to be awarded the L7 designation on the HFMA Strata L7 cost accounting adoption model at Owensboro Health in 2019. Leon Corbet serves as a director for the decision support team who helps some of the largest and most influential health systems in the United States find more margin to fuel their missions and serve their communities. Leon also assists with the product development team's work on the decision support solution, including recent co-development efforts with the Ohio State University Wexner Medical Center around episode bundle payment analytics and the Children's Hospital of Philadelphia around strategic pricing, a tool which leverages cost accounting and contract modeling and analytics to help healthcare systems create defensible pricing strategies. Leon has an MS in Industrial Engineering and a BS in Biomedical Engineering from the University of Wisconsin. Leon, I'll turn the floor over to you to begin today's presentation.
All right, thank you very much, Brian. So, as Brian said, we're here today to talk about time-driven costing, right? How it's allowing organizations to help bend the cost curve using advanced costing, but to scale. And as I said here, joined from 2 gentlemen from Montefiore and Owensboro Health. So very quickly, what are we really going to talk about here for this next hour? So first up, talking about data. Right? Time-driven costing is very much a data-driven approach. So being able to understand how to get this data out of your EHR system and into your decision support system is key. And then being able to understand how to validate that as well will only help to build trust and make it more usable within your system. Next up, we are going to talk about best practices for actually using this within a cost model. Where is it appropriate? What can you use it instead of, right? And what are all the different areas really where you're able to leverage this advanced methodology? And then last but not least, we're just going to talk right about how, right, at Owensboro, at Montefiore, they are using this information, right, to be industry leaders and really provide this to make a difference within the organization. Right? The key to any decision support system, right, it isn't just about being able to, create accurate cost information that's easily accessible, but it's also about being able to leverage and drive action out of this data itself. So we did do introductions here in the beginning, so I will just skip over very quickly here. So before, my name is Leon Corbet, Director of Decision Support at Strata Decision Technology. If you are asking questions as you're going throughout here, right, Paul Anderson, he's the one kind of manning it behind the scenes. He is our product manager for decision support as well, but then Jeremy representing us from Owensboro Health in Kentucky and Jason from Montefiore in New York. But all right, let's dive in. Right, I like to, it's going to be a very much interactive session here for this next hour. So Jason, why don't you just tell us just a little bit around, at a summary level, what does time-driven costing look like at Montefiore?
Sure. So we're relatively new to Strategize DSS. We went live late 2018 for the 3 Montefiore Medical Center hospitals and 2 ambulatory campuses and the hundreds of physician practices that we're currently costing. And since TDC was just becoming available during our implementation, we made the decision to forego a lot of RVU studies and to design straight to time-driven costing. So perioperative, of course, was first. Then soon after, we costed out emergency visits, then all op time, epic op time, managed procedures, including cath and GI endo, interventional radiology, PACU, anesthesia, and labor and delivery, if I remember them all correctly. Then lastly, we deployed all imaging modalities. So we now have only one single RVU study for the virology lab, which strangely and sadly is getting a lot of activity these past 2 months with all the COVID testing that we're supporting. So in short, we heavily use TDC design, have bypassed RVUs as a design costing paradigm, and really have applied this to all the big time variant procedural departments and loving it.
Great. So we'll be diving a little bit deeper in there too to see how much you all love it. But no, appreciate that very much, Jason. All right. Well, Jeremy, same thing. Give a nice summary of how is time-driven costing being used and leveraged at Owensboro Health.
Sure. A lot of similarities to what Jason was saying. We went live with our DS model in 2018. And because time-driven costing was really becoming more prevalent at that time within Strata, we also forewent a lot of the RVU studies where we could, the primary one being our main OR where we brought in op time, time study or time data to do our costing there. A few months after that, once we had a little bit more time to breathe, we started working with Strata to bring in data from other resources to implement into our time-driven model, such as tracking of nursing movement within rooms, and it also extends out to our techs as well. So we're trying to get some imaging time and our nurses' time down to the minutes that they were with the patients. That's kind of what we've been developing and hoping to get a little bit better.
All right, great. Okay, so a lot of similarities between the two, but at the same time, there's I think little key differences between it. So great. Appreciate that very much. So yes, I know we've already mentioned this name a few times here, time-driven costing, but what exactly is time-driven costing? So I'm just going to speak here very quickly, show a little examples of what exactly we're talking about before we dive into some more questions. But for those of you familiar in the industry, right, this concept of time-driven costing, or just using time, right, to be able to drive your cost allocation methods, whether it be for labor or some other expense, isn't necessarily a brand new idea, right? The Harvard Business Review came out with this very, very extensive discussion around how time-driven activity-based costing, right, can be used to really get the most accurate cost for a particular procedure. Right. Ultimately, what they were proposing and they discussed was that, okay, you go ahead and bring in and actually track out all the activity associated with a particular procedure, bring in the timestamp information, get it, right? It can be used to, again, purely accurately have that labor cost, and also at the same time being able to identify variation, looking at ways to eliminate waste, whether it comes to overstaffing, understaffing, and so forth. But if you peel back the onion a little bit in there, right, it did talk about how, what was required was frankly a lot of manual work. You had to go in and manually estimate the staff counts and the skill mix and how long they were doing during each task that you were breaking out into a nice process map. And this was really with only one procedure, right? So if you wanted to go ahead and do this for, either different surgeries, right, in different areas within your hospital, right, or different types of patients, you had to repeat that manual effort every single time. So while it 100%, the problem that it was trying to solve is a great problem to solve, right? This did need to be done, right, within the industry, this move away from a more RVU approach. But the only problem with it is that this approach to time-driven, activity-based costing just really wasn't scalable, right? It required at the end too much manual time and effort to be able to go through and calculate this. And for those of you cost accountants out there, time is of the essence, right? Like you only have so much we can use for it. So being able to, put that in areas that have a bigger bang for the buck, very important. So that's where time-driven costing comes into play, right? Because what time-driven costing does is that it takes the billing activity that you're already feeding into your decision support system, right? Traditionally, what you're calculating and allocating costs to, as well as integrating employee-level payroll, right? And that's what's kind of key on here is being able to bring in that payroll information, employee-level information. But then the missing piece, frankly, that that wasn't necessarily available at the time of that Harvard Business Review article was timestamp information, right, from an EHR, but as Jeremy mentioned, we'll be talking about maybe from other systems as well, right? Bringing all three of these together, right, really enables, right, the automation to be able to quantify the cost at a patient level, right? That's key here, right? RVUs are always done more at an activity type level, whether it be a charge code or a CPT, but it also opens up the door to look at staff level variation when you're able to provide that staff detail. So because of this, you can go through, right, you can look and identify waste, right? You can search for outliers and so forth. But really, at the end of the day, why this was so successful is that it leveraged the automation, right, to achieve scale across the continuum of care. Right? Anywhere where you're able to bring in timestamp information, you can leverage that and have that drive your labor allocation. Right? There's no manual entry, right? There's no, hey, a new procedure gets done, so we have to do a process map and so forth. Right? It all gets automated, and that is ultimately what's key to using this methodology and why it is so advantageous. So to provide a little visual what we're talking about here when it comes to it, right? Over on the left, talk about RVUs a lot. We're going to talk a lot about RVUs, right, for this next 50 minutes now. But you can see here if you look closely, right, the real downside with using an RVU is that it's not patient specific. Right, so all these different patients we're looking at had the same procedure that was done on them, right? All got charged the same. And so thus, as a result, the unit cost is going to be the same. Right? Versus with a time-driven costing approach, you can see here, bring in that timestamp information, right? In this case, looking at our surgery RN time. And let's have that drive the actual cost associated with each one of these patients. All right, so I said, it's a very data-driven approach. We have to bring that data, that timestamp information in from EHR or other health systems. So let's dive in a little bit to understand, well, what is that type of data? How do I get that out of the system, right? And then, once again, how can I validate what that is? So I know this was always my first question, right? And especially for those of you who are more users of, costing data, decision support data, or so forth, maybe the only advantage right, using the RVUs or time-driven activity-based costing, it was manual, so I knew where the data came from and I could ensure that it was high quality. But now that it's automated, I'm getting from a system and I have to integrate it. How can I really be confident that the data is high quality and it is valid? So first, I'll turn it over to you, Jason. I have some supporting slides in here as well. Why don't you talk a little bit around what you, Montefiore, was able to do to help alleviate some of these concerns around data quality, data validation?
Absolutely. Going to go to the next slide?
Yep.
Perfect. So first off, one of the critical capabilities that my team has is we can design our own data extracts out of the data warehouse and out of Epic Clarity and Cogito. So untethering ourselves from the need to get into the IT project queue was a great help, in speed of execution of the TDC designs. But that didn't alleviate the need to address our, quality challenge data. I'm sure we're not the only ones out there. Each of these three core TDC designs have different data sources and different data traps, trademark pending on that term. So let's just go through each of them. So the first one is OpTime for the OpTime managed departments, peri-op and L&D and GI, endo, and so on and so forth, all the procedural departments managed by Optime. So we are users of Cogito, and they have a wonderfully designed surgical case fact, which I just took advantage of. So all the timestamps, the nurse and tech check-ins and check-outs, anesthesia start, anesthesia stop, all pre-calculated for us using this table. But with that said, there's still an inherent process that leads to data flaws, and these are the hanging checkouts, so check-ins with no corresponding checkout. So we do a bunch of checks to, if there's no anesthesia start, then take the in-room start date timestamp. If there's no out of room and that's null, then take the end of the procedure. And there's about 15 or so of these. If null, then take the best proxy, assuming that's not also null, and calculate the durations at the other end of filling in all the blanks. The other major department and data sources for imaging modalities. So this was a very different design. We went to actual hospital charge transactions and married that up with a imaging view that is created within Clarity and bumped that up against the actual order information that ordered the imaging exam. Our data traps for this is a little bit more straightforward for various reasons. If the radiologist doesn't interpret, there's a hanging end time of the exam. We don't have DICOM turned on, so I wasn't able to gain access to actual machine on, machine off, the Tesla coils on, Tesla coils off. So we're more the RIS time-stamping data source from patient arrive, exam starts, exam ends. And sometimes they're hanging, or it takes several days for the end exam data to show up. So in those situations, I just apply an average duration imaging exam per charge, and for any charge that has a missing duration, I just divide by that average, and for this transaction, here's the average duration for this type of procedure within that modality. And then last but not least, emergency departments. So emergency departments, very messy data. It's just I think the nature of the process of patients coming, leaving against medical advice, turning around and coming right back, and this creates a lot of data challenges within the event log. So we use the event log for ED, and there's hundreds of events, the obvious ones: arrival, triage start, triage stop, room, then departure, the main ones that we use. And sometimes, there's two arrivals. So we have to trick the system to recognize there's a second arrival and ignore the first one and use the timestamps from the second one. And the same with the actual event times themselves. It's very sensitive to the end time of the previous event and the start time of the next event. And sometimes there's issues, and the subsequent event could start earlier than the end of the previous event, which creates negative duration. So we detect those and use other timestamps like the transaction, what's called the recording time, if the actual event time is misaligned. And then, at the other end, when I run these data extractions, always looking for negative durations, and if any pop up, investigate what it is, what's the pattern of the data, and design yet another data trap to address it.
All right, great. And would you say, going through looking at it, how often do you know if these data traps were triggered? Is this something that this is a majority of the time, 65, 70%, or is this really just catching more of those one-off cases when whether it be a fat finger or something to talking about just the nature of the process?
Yeah, interesting question. I don't actively monitor the hits of the data traps. Just for anomaly data that needs yet a new logical data trap. But in the beginning, when we were first designing them, I would say it's the anomalies. It's definitely not 60%. I would say 2% off the top of my head. Especially on the ED side, that was the messiest data. Imaging was pretty pure, and uptime, the OR, et cetera, procedural data, hanging, timestamps, check-in, check-outs of nurses. I would say, I don't know, 3 to 4% of the OR case logs had these danglers that we needed to fill in a guesstimate of the date timestamp.
Gotcha. And what was the cath lab? Was that part of one of the uptime managed departments? Did you see that?
That is correct.
In there?
Yes. Cath lab, GI endo, correct.
All right, perfect. And I'd say same thing with that. Similar. It wasn't like that was necessarily any different than the actual operating room, correct?
Yeah, cath lab's a little bit more consistent. Those procedures are consistent as compared to the OR suites where, anywhere from a heart transplant to a appendectomy is going on. A cath's a cath, and they're pretty consistent. So yeah, not as dirty as the pure OR suite information.
All right, great. And then when it comes to the kind of monthly checks that you're doing, what else you and your team kind of put in place here to just to ensure that, hey, this data looks right. Again, the traps take out a lot of those one-offs, but is there anything else?
Yeah, absolutely. Well, we're looking at it. This is my TDC monitoring report. So we load timestamp data on a monthly basis as we speak today. We're working on moving the code into production and be part of the daily data integration cycle, but alas, that needs IT intervention to productionize it, and it's taking a while. There's always a project. We're implementing Epic and new institutions and COVID. It's one thing after another that is delaying that. So for now, we manually do the loads on a monthly basis, and this is one of the standard data validation reports that we use, and it just lets us know that things loaded correctly. So as we can see here, there's been times where I've forgotten to change the date parameter, or I put the wrong month in, or sometimes even especially in the early months, I forget to change the 2019 to 2020. So there's always something that could potentially go on, but this is a nice view over time by the various departments that are using TDC, and you can see the many different timestamp fields that we've created in the reporting database in the cube, and you can clearly see that February we're not ready. This was from our February cycle, early March. So only a couple of weeks have been loaded, and so I went back, double checked the parameters, reload the data, and see that we're getting about 140,000 in surgery minutes and about 150 minutes in imaging. So this is the final check before we actually start running the cost models.
Yep, makes sense. And are you doing anything with this to look for, say, like outliers? I imagine that, and again, the data traps, I imagine capture some, but is there anything else you're looking at specifically with outliers?
It's the mute button.
Okay. All right. Well, Jeremy, why don't we turn it back over to you? What about what's happening at Owensboro? Right. What are you guys doing? Some similar type of checks, similar tests? Is there anything? What does that look like?
Yeah. So in Owensboro, what we're doing is we're really looking for cases post costing that stand out. For instance, we'll be running reports, and you'll see like one account at a high level that just has 10% of the entire department's cost. So it's like that's clearly a problem. Like there's something wrong with the minutes there that need to be addressed. We kind of call that the low-hanging fruit in that situation. Those are the easiest to spot. After that, we're trying to find instances where we can run trend reports to see where minutes pop up, whether that's at the procedural level or even the physician level. We're just really looking for any kind of hiccup in a trend at different levels to see, hey, maybe we need to dive in and examine what went wrong with that one. And a lot of times, similar to what Jason was saying, it's where an open-ended record made it through, even though we have some of these catches in place. something will happen where it'll pass our logic, and then procedure will have 1,000 minutes for a nurse aide or something like that. So even though we have some of these things in place, we're still having to watch to make sure that that the data still is accurate and usable, whereas we can't just rely on it to be that way each month.
Gotcha. And you, Owensboro, you use time-driven costing in a lot of areas, right? A majority of your services are actually, you're using this to calculate, the cost for it and so forth. So does that make this, I don't know, any harder, right? Do you see a lot more outliers? Do you see this as something that's taking a long time to do?
It just is different. Like in areas that we're not using time-driven costing, most of our time is spent just reconciling at the department level, making sure that the data is flowing the way that we want as a whole at the department. But in areas that we do time-driven costing, we're able to focus on patient-level reconciliation. So if I'm looking at an area that doesn't have time-driven costing, I just want to make sure that the bottom line works because everything's going proportionately. There's nothing else to worry about. But in these, it's just a whole different mindset. I'm having to look for anybody that just bucks the trend, anybody that looks like an outlier. And I think it's a little bit more enjoyable to reconcile it that way and do auditing that way because you're going after real results. You're not just doing things that are from like a theoretical standpoint. You're looking for real problems that need to be fixed.
Yeah, no, I like that. You could say it's more value add type of analysis that you have to spend time on versus your more traditional, is the system doing what it's supposed to be doing type of deal.
Exactly.
Okay. All right. Well, thank you both here. So, we had some questions coming in. Thank you for answering some additional ones as well. I'm sure we'll be getting more, but let's move on now to really the next part of it, right? So yes, we have data in the system, right? It's something that we're going through, we're validating, making sure, right, that it is usable, that it is allocating costs out correctly. But let's talk a little bit more around, okay, well, but how do I actually use this in my cost model? Or what did that process look like? Did this replace or did this change anything associated with it? And we're going to start first with the OR, because this is, area common between both organizations are both using this with the operating room, kind of low-hanging fruit we like to talk about. You get this information from Uptime, right? It's able to cover all, right, sort of services that happen within the OR. And Jason, I know you mentioned this before, right? You said manual RVUs for really what you were doing now. And wait, actually, both of you said this. Both of you using manual RVUs, and you both kind of held off on it. So
that's correct.
Was it just that easy? Was it just, did it work in any way? It was just kind of plug and play, or did your organization have to make any sort of changes to, how you charge things within the operating room? I said, Jason, maybe you can go first.
No, we have a pretty overly simplistic OR charging paradigm. It's a single 30-minute time charge. They're talking about adding complexity, and we're working together to keep things in sync. But no, it was straightforward, one charge, one operation, attach all the minutes to a single charge. I know it's a little bit more complicated, could get more complicated for other institutions that, have a base 30 minutes, then additional minute charges, and figuring out how to spread a duration of a single operation over multiple charges is a little bit more complicated, but we thankfully didn't need to deal with that.
Great. That's very nice. Jeremy, was that a similar experience for you at Owensboro?
Yeah, we didn't have to change how we charge for surgeries. We do a version where there's base and increments involved in our main OR. However, in our cath and endo suites, we charge at the procedural level. So we got two different methodologies going on at once, but we were able to adapt how we attach the minutes to the patient in each respective situation differently. So we were able to accommodate what we needed to get for the costing purposes without having to anger a lot of billing people and processes.
Yeah, no, that's a very great call out, because both of you know, right, if changing how things were billed, if they were designed maybe by a cost accountant, things would be very differently, but we know that they're there for a reason, so typically have to work around what this is. So this was great that it seemed to be more of a really a plug and play type of deal with it. And we'll continue on here too to talk about this, because as I said before, right, time-driven costing, at least for us, right, or organization, it sounds like too, right, we really started us on a journey focusing in just, right, on surgery, right, within the operating room, right, but now, and we'll have you two speak to this a little bit more here, right, we're now support this across the continuum of care. So, say, very same question I'm just asking before with the OR. Jason, I'll start with you, right, emergency department, imaging, sound like two areas able to leverage this. Was that similar experience? Did you have to, is there any kind of gotchas you had to work around? Did they have to change how they were charging things? What did that really look like?
No, I wouldn't dare ask our revenue cycle operations folks to change charging to suit me. So yeah, that was a working assumption that I would conform to prevailing charging activities. But the other anesthesia is anesthesia. That's not even time-based like OR, 30-minute time-based. That's just a setup fee. So that was very easy to attach actual anesthesia duration minutes to cost out the CRNAs. We are not doing clinics. Physicians, we're not doing TDC yet. That's next on the docket. Right now we're using RVRVS, the worked RVUs at a CPT level to do the allocations. But next on my list is to attack the clinics and the physician practices. Imaging, also procedural level. So for every exam type, there's a charge code for it. And then, again, very easy to attach a duration to the charge transaction. Again, following the charge router from the order to the point of the charge generation, and that's how we attach the minutes. Nursing, I'm very jealous of Jeremy. we do not track via RTLS time in the room. I'm very, very jealous. So also on my list to see what we can capture out of Epic to do some patient-level room and board adjustments, but it hurts my head to think about it. So again, kudos to achieving nursing TDC design. Very impressive.
Yeah, I know. I think we hear that a lot. Jeremy's in a very, very, very good position here. One question we did have, though, Jason, with imaging, looking at the physician time at all, is that something that's part of this, or is this looking at more of the tech time?
Well, it's two different billing systems. So the technical charge is, at the point of interpretation, a charge is dropped. We have the duration of the exam. So for a single chest X-ray, it's very nice to be able to, a infant took an hour and sedatives versus an adult, and it took 30 minutes, and we see that variation within the same charge code. The physician activity, the radiologist activity is on the physician billing side of the world. So whatever CPT that radiologists build for the interpretation, we would cost out using the worked RVU. As I mentioned earlier, practices are on my list to see if we can squeeze any juice out of capturing time. So I don't even know if it's possible. How long did the radiologist sit there and interpret? I don't know if that's data that's readily available. I haven't even investigated it, but for now we're using the worked RVU attached to the CPT code to cost out the radiologist time.
Gotcha. No, great, perfect. And when we say cost here too, one thing to keep in mind, we're talking about calculating a cost rate per unit, right? So, in the OR, we were talking about that unit would be by, right, that actual OR charge code. And one thing to keep in mind too is, organizations set those up all differently, but that's kind of the advantage of using this time-driven costing approach is that, if you're an organization who does by 30-minute increments or 45 or 60 minutes or even a per minute, right, this is still allowing you to bring in that staff and specific time, right, and applying it to each one of these. So it's just one call out I have on here is it's like we're always talking about, cost per unit, just using this time to drive it. But Jeremy, question for you then being, right, so great. Jason, I just said we're very jealous and we hear that a lot. What are we jealous about here? Is, are there areas that you're supporting time-driven costing that's, have made this a little bit easier? Is there some additional data that you're using for it?
Sure. For the nursing one, we actually got really lucky in the sense that about 8 or 9 years ago now, our organization started putting these RFID trackers on all of our nurse and support positions. I believe it was more for a compliance reason, but I found out about it, and we worked with our IT department to work on getting that data out and repurpose it for this. So it's really amazing. Not only has our organization supported being able to do this, but we already have 8 or 9 years of historical data. So that's just when I tell people about the L7 stuff, I always just say we got lucky in a lot of areas, and that's the biggest one. But with that nursing data, we're able to see, based off of that RFID tracker, that a nurse went into a room and they spent 8 minutes with that patient. And then they went to the second patient and they spent 32 minutes in there. And that data is able to be compiled and summed up at the per patient level per staff member, so we can more closely attribute their costs directly to the patients that they serve, as opposed to going into just a generic nursing bucket that would be allocated proportionately out to all patients that came within that department. So, well, and we're still working through all of it because it's so new, but it's really exciting to see the fluctuations of how much time different patients took of our nursing bucket, of our nursing pool. And even more so, I know we're going to talk about it later, but it's going to be really interesting to see with this COVID stuff going on, how much more time that those patients take versus our regular patients. So we got really lucky, but we're like Jason. One of the things we want to do in the coming months is to start looking at the clinic level. That's one of our organization's priorities, to continue. Like, our goal is this continuum that you had shown here, and we still got a long way to go.
Yeah, gotcha. You kind of answered two questions here. It sounds like, yeah, so on the clinic and physician side of the world, it sounds like there's still some work that needs to be done for it, which we're starting to tackle, of course. But then what would you say? Again, you said saying nursing. I mean, is this all nurses? Does this cover, 100% of where they're going in and out, on their shift?
I was told it covers everywhere except for the bathroom.
All right, great.
Bad joke, but allegedly it does track them everywhere they go, and whether it's in patient rooms or if it's in non-productive bucket. So, like, if you add up all the minutes for a nurse's shift, it won't total up to the full 12 hours that they were there. So it allows us to say, of that 12 hours, 7 hours was spent directly in the patient's room. The other 5 hours is probably charting time and things like that then we do attribute out a little differently than the direct ones.
Gotcha. Okay, great. That's perfect. Thank you very much. So 2 other additional questions here, kind of bringing back a little bit of the validation here we're talking about. So, yeah, well, actually, you know what, Jeremy, we'll stay with you here because, again, that's covering a large percentage of services, right? Were there any hurdles, right away when you started using, right, this real-time tracking data within the system?
Yeah, especially with the nursing one, it's how do you get that to the patient accurately without duplicating minutes being attributed, without having to change your charge master or billing practices. So similar to like an OR situation, we're trying to make sure that the minutes get attributed maybe to a room and board charge. But what we found is sometimes it doesn't always work out cleanly the way we want. So it's going through and spending time observing how the data flows in relation to the charge master and working to determine, almost like a series of if statements, like if this, then go here, then if this, then go there, developing that rule logic that can help you get these minutes the way you really want them to. And after that, it's just spending a lot of time validating that with maybe the nursing managers, people a little closer to the live data. Because, at this point, you're kind of taking a scientific approach of how you're going to get it there, but I don't know every single patient that comes through all the floors. So we rely on subject matter experts to chime in and work with us. And if we find some outliers, we run by them, and they'll say, oh, yeah, that patient really was here. That truly was an outlier, but it's right. Just relying on people that know more about the subject than us, as opposed to just bringing in all this time data and just assuming it's right.
Gotcha. So, Jason, do you have a similar experience where you would say you maybe had to talk and, use additional or resources that maybe traditionally you weren't used to having to talk to when it comes to cost validation?
Yeah,
would you say that was true?
Yeah, I would second exactly what Jeremy said. Engaging with operations and getting there, I guess two-step input, is the data representative of the reality on the floor? And this is what we plan on doing with it. Does that design make sense to you? And getting those two inputs. And that's what we did with, peri-op leadership as an example. Gave them the numbers, the capacity utilization percentages coming out of the data, and literally sat there and did back of the napkin calculations. All right, we do 55,000 operations, and on average, an operation is 60 minutes, and average staffing pattern is one nurse, one tech. Do the calculation. That should be 1 something million minutes in the suites. And we also know we paid 1.6 million productive minutes in terms of productive payroll. That's 63-ish% utilization. That sounds about right to us. So yeah, having those conversations is critical. Just so, I know that the data makes sense, and getting active sponsors and ultimately consumers of the data involved in the design.
Yeah, great. Yeah, we're going to come back here towards the end because it sounds like already that this is helping solve some other traditional problems of decision support, cost accounting, getting this cost information out. But before we dive into that, what would you say? And Jason, we'll stay with you here. What really was the biggest difference in costing validation before and after? Would you say it was this? Hey, actually, I have to now work directly with the operators, right, to make sure this is valid, or was there something else?
Yeah, as you said earlier, this is a data game. So it's less about, tweaking the cost model. And so it's really a shift to the front end data capture and data validation activities, shifting away from a lot of post-running of the model validation. So I really don't spend much time anymore on a monthly basis validating the cost by each imaging charge code and each patient or OR suite, and it's much more about making sure the timestamp data makes sense going in to the cost model in the first place. I think things are going to blow up a little, so I will be spending a little bit more time post-model. Probably other institutions that are on the call, we've turned off all elective surgeries because to prepare for the surge for COVID. ORs have been turned into ICU rooms. Our PACUs are ICU beds now. We even transformed a conference center into an ICU staging area. So my cost model is going to be very, very confused the second half of March and more importantly in April. So I'm going to have room and board charges appearing in operating room departments. And so I will be spending a lot of time making sure the cost model is resilient enough to figure it all out, and what little surgeries we are doing indeed continues to use timestamps, and for the room and board charges that are starting to hit, we are on an RCC basis. I don't have RFID tracking information like Jeremy, so we RCC at a cost center nurse station level. So for this strange period, we'll definitely be doing validation on both ends. But that's the big picture, a shift to the front end data integration, data validation, and less, checking the raw cost model results month in and month out.
Gotcha. Yeah, and Jeremy, let's say last question here for you too on this. One thing, I imagine massive differences maybe now, and when it comes to using in this real-time tracking data, right? Did you see though that like cost drastically swung, where it was like wow, or very different than what it was before and after using this, or did it more or less line up more with like acuity, think patient illness, DRGs, or so forth? What was that? Was that a big difference? Was that like now it was totally different, or more or less did it align-ish with it?
Being that we were really just dealing with the nursing time, I think the minutes themselves did vary a lot, but the overall cost didn't change as much as I thought it would. I thought there'd be big spikes and valleys. But we're talking about minutes at a not like a low paying position, but it's not like a surgeon or something like that would have drastic pay ramifications by there being different minutes. So with that, it was like it was useful more from like a resource management perspective, but not to say it's not useful for the cost. It is, but where you start to see the peaks and valleys and things is really when you're looking at the minutes being used. The costs kind of fall in line. At the DRG level, not a lot changed. It was just very minor things, but it also just helps us feel like our model's more accurate and we're more confident in the results when we have things like this behind it.
Okay. Yeah. No, that makes I think that makes total sense. Kind of what we would figure too. Yeah. It isn't like we're talking about massive changes at an overall cost level, but it's the devil's in the details there. And then yes, the confidence factor I think is huge, being able to trust this. And it's a very good segue really into our next part of this, is now ending on here. How are we utilizing this data? Like, how are you using this, right? Is there some advantages? Is there things you've been able to do now that you weren't able to do before, and so forth? So, we'll go ahead, Jason. Anything really on your side of the world where, are you looking to use TDC specifically within the OR? Oh, I guess, sorry, Jason, I should say too, with that, like, are you looking on more on the capacity side of the world, like being able to check in and see, okay, yeah, hey, our operating rooms are like functioning at capacity? Are you able to do some sort of that type of analysis now that you have time-driven costing within it?
Absolutely. So this report is the one I referenced earlier that we designed and used for validation with the peri-op leadership. As you can see, the big red numbers, they were initially shocked. We were initially shocked by the utilization numbers. But again, we did that back of the napkin exercise, 55,000 surgeries, staffing patterns, 60-minute durations. Yeah, it's about 8 million minutes per year, and that lined up with the timestamp information, 7.7 million that we have here for nursing. But we paid out 22 million in productive payroll, converting hours into minutes. So the name of the game and the hot topic is staffing to demand. So we have a new VP, a peri-op, a physician who's come on board, and this is one of the strategies, and using this data to understand by day of the week, why are we staffing full complement of techs and nurses on Friday afternoon when we're running 25% utilization, because all the doctors are off golfing. No surgery is happening Friday afternoon, but that's how we have traditionally staffed, steady state, no matter what day of the week, no matter what shift. So working with unions and schedulers and the block managers and with the surgical divisions, to right size operations, now backed with, actual facts and data. This, was the first time they actually seen side by side actual OR suite utilization and productive payroll of the nurse and tech staff. So it was eye-opening, as we could see with these numbers. 30-something% for nursing is not a defensible utilization of capacity. So they're actively going after it.
Yeah. No, I mean that makes sense. And it's been great, again, touching on the trust piece again here too, where it's like, yeah, hey, like, these are numbers now that we trust. So when we're coming to the table to work with you, we don't have to spend that time being like, well, how did you come up with this number or do this number, so forth. It's great. Did you also were able to look at this at all, to look at variation even with staffing, right? So, are there, particular trends or different surgeries or different physicians who maybe would use more staff than others?
Not quite yet. I guess the only example where we really went that deep, we're opening a spine center where both neurosurgeons and orthopods do lumbar, upper spine and lower spine procedures. And we did look at timestamp durations of, the same DRG, a lumbar spine fusion, and the vast difference in both time in the OR as well as length of stay and other, I guess, downstream implications of, longer under anesthesia, more complications, stay longer. So that definitely, you could see that in the data. So that's an example where we've used this blend of time and costs for setting up to perform program planning.
Gotcha. And Jeremy, what about you? Right on at Owensboro, on the OR side, able to look at any sort of capacity type analysis, any sort of variation when it comes to staffing?
Yes, like we're really focusing on how we can identify variation for the surgical cases. So a lot of the things that we will do will be at the procedure level. So we're trying to see, who's using more minutes at certain positions. What can we do to try to get them on a level playing field with the best person amongst their peer group? Things like that. That's really where we've been focusing our efforts on.
Gotcha. Okay. All right. Well, perfect. Well, thank you. Okay. Well, getting towards the wrapping up here, just have a few other just additional questions that we'll talk about. So one, and Jeremy, I'll stick with you here. Right? What are now some common questions that you're getting from users? When I'm saying users here, maybe think people who've already been asking you or used this data, say in the past, right? Now, what types of questions are you getting now that you are using time-driven costing?
The primary thing at first is we have to just explain to them how we're getting it and how accurate it is, and then we have to get that buy-in. Jason was mentioning before. We have to get them to believe in the data. So a lot of our time is spent more or less winning people over. But then after we've won them over, a lot of the questions that I've been getting would be like a doctor wants to know why another doctor is better than them when it comes to staffing. So this allows us to really focus in on the staff types used in the surgical cases. And we can explain to them, well, you're using 3 of this one position on average, and they use 1. That's going to add up. That's going to increase your cost. And maybe we can work with that best case provider to see what they're doing and maybe get you on a level playing field with them. Whenever we put out a list of surgical procedures where doctors or it shows the variation amongst doctors with staffing costs, they immediately want to know. So all of our questions really have been focused around, doctors asking us what they're doing wrong, what they can do to improve, and then we work with them to identify where they can improve so they can focus on that.
Gotcha. Perfect. That's great. That's great. Jason, what about you? Any common questions you're getting now that you're using time-driven costing? Yeah, sorry.
Yeah, well, as a reminder, first and foremost, using TDC for me is to improve the allocated cost. So it's really an improvement in costing. Secondarily, yes, the actual information is useful to certain types of users. One of those users for me is a management engineer, as an example, who works in the emergency department. So once again, staffing to demand is a hot topic, and he's using this information. So we have all the dwell time, triage time, the room to departed time, and marrying that up to the productive payroll of the nurses and techs and other types of staff in the EDs to see how they line up. And not surprisingly, they don't line up well. So, very much like the OR story, very steady state. OR is going to have 15 nurses, no matter if it's Tuesday afternoon or Saturday night. And they're using this data to, again, approach unions and schedulers and leadership, emergency division leadership to move towards staffing to demand and get a little bit more smarter. We only need 6 nurses Tuesday afternoon, generally speaking, historically speaking, not 15. So we'll see, as we engage with, leadership, clinical as well as operations leadership with the other departments, we'll just rinse and repeat and do the same type of scheduling, staffing to demand for the cath labs, for interventional radiology, et cetera, et cetera.
Okay, great. All right, I know we touched on this a little bit throughout here too, but are there some areas now that you're looking to expand time-driven costing next? Jason, we'll stick with you here. Any areas?
Sure. So I consider it a gauntlet laid down by Jeremy. So inpatient bedside nursing minutes is a stretch goal that I'm going to go after. I know we don't have, RFID tracking, but it'll be more, are there documentation and EMR, medication administration records and things like that, the IO worksheets, et cetera, that we can capture out of Epic ClinDoc module and, try to attach minutes, nursing minutes to each patient. I'm sure for, offline conversation with Jeremy, when you have semi-private rooms and there's, 2 or 3 patients in the room, how do you know exactly which patient the nurse was seeing? So all those kind of things tickle my curiosity, but we'll go after the documentation route and see if we can get a nice data set to do time stamping. And as I mentioned earlier, the other big target is practices, clinics, hospital clinics and practices. So we're using our RVUs, worked RVUs now as the charge allocation weighting system. Does it make sense? Is there enough variation to justify a switch to an actual, CPT, 30-minute initial patient visit, so it's going to be on average 30 minutes, right? So I'm not sure, knowing that it was 29 minutes or 27 minutes or 32 minutes really drastically changes the resulting unit cost. So we'll have to go through the exercise and call out of the Cadence system, actual FaceTime and telephonic, and there's all, it's not just FaceTime. There's all types of visits and inpatient rounding and things like that. So that's another target on our list for 2020.
Gotcha. Now, I'll kind of, before I switch over to you, Jeremy, kind of ask the next question on here as well. Just a hot topic here at the moment. So, Jason, how has this helped really with costing and understanding the cost for COVID-19 patients? Have you seen time-driven costing make a difference for you?
Not quite yet. Challenge number one was identifying them. Thank you, Strata, for offering up some of the patient population techniques, and we're doing something a little different. We're actually accessing the pathology results and flagging patients that way with positive and detected COVID. It's really going to be, as I said earlier, since we've repurposed so many of the spaces, cath labs, ORs, PACUs, AMP-Surg buildings into inpatient ICU and med-surg surge capacity, I need to keep track of how the expenses and the resulting costs are going to flow through the system. And it's a little too early to do that, unfortunately. It's really the April activities where the surge took hold, where we're actually placing people in ICU beds in the converted PACU spaces, even in gyms. I don't know how to do the gym one. So the short answer is not yet. They look like any other patient. It was really identifying them. We're nearly 99% COVID patients in terms of census now. Electives were turned off almost a month ago now, so it's only heart attacks and deliveries that are still flowing. So, you're in a nurse station, you are COVID, and, every payroll minute that flows through that cost center is being allocated to the COVID patients. And really, there are no surgeries. There are imaging has been interesting. So imaging, of course, is a highly used ancillary for chest X-rays. So we're, starting to take a look at that. But, a chest X-ray is a chest X-ray. A COVID patient is, we'll see if their durations tick up because of precautions and isolation, the handling of a known COVID patient, and disinfecting the room after each exam, et cetera. We'll see if the durations, again, it's still too early. The data literally hasn't even flowed through the system yet to detect that. It's going to be the April cost model where we'll see these effects.
Yeah. And Jeremy, what about you? How Is TDC, has that made your life easier in these times?
Yeah, it's helped us because, with the Nursing Minute part of it, we were able to already have a baseline that we were able to use for estimates for what we think maybe this is going to impact us on. So a lot of the relief effort reporting that we're trying to get ready for, we've got these placeholders in line that are allowing us to kind of just be ready for whenever the real data does come through, like what Jason was saying. We're going to be doing our March costing starting on Wednesday, so this will be our first instance of having COVID patients with cost attached to them. We haven't had a lot here in our city, but it'll be our first attempt to get this attached to them. So we'll be able to see how close our estimates were using historical time-driven costs compared to actual COVID time-driven costs.
All right, great. Okay, well, I know we're at time here. There's just one last additional question. I'm glad someone asked this too. I think, Jason, this is with both of you, but I know, Jason, I've asked you this a few times. But, right now we're talked a lot about this, how it's allocating out labor costs. Are there any considerations to use this to allocate things outside of labor?
Absolutely. I'm working through a bug, not to scold Stratter on live TV here, but I'm also trying to use the total duration of the operation in combination with the plan for complexity level charging that is being designed, so I can allocate equipment depreciation and operational equipment, which are two separate cost components for us. So if I know there's a perfusion equipment in the room for a complexity level 5, I will use the equipment minutes in essence to allocate to each individual patient's OR time charge. So absolutely.
Perfect. Okay. And I guess I know I've said here, Jeremy, anything, same, would you echo what Jason's saying, using this maybe now equipment depreciation, some other type of areas?
Yeah, that's definitely on the outlook for us. Right now, we don't have anything in play, but it's something we want to focus on moving forward.
Gotcha. Okay. All right. Well, so I know we're at time here, right? If anybody's interested in actually seeing StrataJazz, the tool in action, right, you can join us on Tuesday, April 21st at 1 o'clock Central Time. You can register at stratadecision.com/demo. And I definitely want to spend this time to thank you both for here, right? Other things to call out for the group as well when it does come to COVID-19, right? Strata, we're here to help, whether it be providing some live sessions such as webinars, right, weekly office hours, different materials we're sending out, right? You can go to our homepage and we really introduce what we call, right, step 1 on the road to recovery, understanding your cost information as part of our COVID-19 cost capture and recovery model, right? I said focus here today talking about how you can understand that cost. But yeah, I think Jeremy, Jason, if you have anything else in here, I want to say thank you very much for all of this. And everyone out here in the field, right, all our healthcare workers, we really, really appreciate it. Obviously, you're really the heroes that are going on right now. So Jason, Jeremy, I don't know, any last words?
No, thank you for the opportunity.
Yes, thanks, Leon.
All right. Well, appreciate it very much, everybody. Brian, turn it back to you.
Thank you so much, Paul, Jeremy, and Leon, for that excellent presentation, and Jason as well, of course. That's all the time we have for today. And I just also want to thank, on behalf of Becker's Strata Decision Technology, for sponsoring today's webinar. Stay safe, everyone, and be well.
Thanks, you too.